Hi, my name is Fatima Makram. I'm a second year student. I'm going to explain you about the myocardial infarction, which is a pathology, very severe pathology. Now let us start. What is myocardial infarction? So the core definition is the permanent destruction of the myocardial cells or the heart cells caused by the complete or abrupt or complete oxygen deprivation to the heart tissues. Now, primary mechanism, so the blood flow is reduced to the in the coronary artery due to the atherosclerosis, which is the blood clot accumulation and occlusion by the embolus or the thrombus. Embolus is the free-floating blood clot, and thrombus is the other blood clot. Clinical significance: without prompt intervention, which is without any kind of care taken, irreversible myocyte necrosis begins within 20 to 40 minutes of the complete occlusion. And location and types of myocardial infarction. So, left anterior descending coronary artery occlusion, anterior and septal myocardial infarction, most common and often most severe kind of the myocardial infarction. Circumflex occlusion, which is the circumflex artery is involved, posterior and lateral myocardial infarction occurs. RCR, right coronary artery, leads to the inferior wall myocardial infarction. May involve this right coronary artery involves the right ventricle. Now LAD, which is the left anterior descending coronary artery, is sometimes also called as the widow because it supplies to most of the heart muscles, most of the territory of the heart. So pathological classification. So basically two types, transmural infarction and subendocardial infarction. So STEMI, full form of STEMI is ST elevation myocardial infarction. In full form, NSTEMI is non-ST elevation myocardial infarction. So first, STEMI extends through full thickness of the heart muscles caused by the complete occlusion of the coronary artery, and ECG ST elevation is C. And non-ST elevation where it involves a smaller area and mostly the subendocardial wall of the left ventricle, septum, and the papillary muscles. Partial occlusion is seen and no ST elevation is seen on the ECG. So the pathophysiology of the myocardial infarction. So risk factors or causes, which are hyperlipidemia, hypertension, then smoking, diabetes, etc., causes this irritants. And endothelial injuries causes the endothelial injury, damage to the endothelial inner layer of the endothelium and of the coronary artery. Now the lipid deposition. LDL cholesterol is deposited and penetrates in the inner layer. And inflammatory response, monocyte migrates, all the inflammatory reactions takes place. Okay, and also the foam cell. Fifth is the foam cell formation. Monocyte ingests lipids and becomes foam cells, foam-like structure. And then the smooth muscles proliferation. As smooth muscles migrate, and then it starts to proliferate. Atherosclerotic plate formation. As a result, the thrombus is formed. Atherosclerotic thrombus is formed. Fibrous cap forms over the lipid core. Plate growth. Now narrowing. So as the plate grows, so the lumen becomes narrowed and the blood flow is restricted. Thrombus formation, platelet adheres and aggregate to form the thrombus. Again, coronary artery occlusion. Thrombus partially or completely blocks the artery. Now this thrombus would slowly and gradually block the artery and would also restrict the blood flow. Myocardial ischemia. Reduced or absent blood flow leads to the oxygen deprivation and leads to the myocardial infarction. Prolonged ischemia causes the irreversible death of the myocardial cells. Now, clinical representation. Chest pain, radiation, and the associated symptoms. So chest pain, pressure, tightness, squeezing, or burning. Typically substernal lasting and lasting more than 20 minutes. So chest heaviness and tightness in the chest. Radiation, pain spreads over the shoulder, left shoulder, arm, and jaw, and neck and back, and also on the upper abdomen. Associated symptoms, which is cold sweat, nausea, fatigue, lightheadedness, shortness of breath, indigestion, leg discomfort. Now, characterizing MI pain. Quality: severe immobilizing, described as heaviness, pressure, tightness or burning. Location: substernal, retrosternal, or epigastric. Radiation to jaw, neck, left arm or back. Persists more than 20 minutes and relieved by the rest. Now, diagnostic test: ECG, coronary angiography, and chest X-ray. So, ECG, T wave inversion, ST elevation, segment elevation, and abnormal Q waves. Coronary angiography: in invasive imaging to detect the percentage of blockage in the coronary artery and precisely identify the type and the location of the MI. Chest X-ray used to detect the cardiomegaly, means the enlargement of the cardiac muscles, and excess of the pulmonary congestion or the structural abnormality. Now the pharmacological treatments. So drug classes and key agents. So antiplatelet, aspirin, thrombolytic, streptokinase, reductase, and tenectalase, anticoagulant, heparin and warfarin, nitrates and vasodilators, glycerin trinitrate and nitroprusside, ACE inhibitor and beta blocker, captopril and metoprolol, analgesics and antiarrhythmetics, morphine, lignocaine, procainamide, inotropics and others, dopamine, dobutamine, etc. Key takeaways. Now, time is muscle. Every time of occlusion causes the irreversible damage to the heart muscles. Rapid diagnosis and reperfusion are critical. ECG first. A 12-lead ECG within the 10 minutes of the presentation. Multi-drug approach. Effective management combines antiplatelet, anticoagulants, nitrates, and reperfusion therapy. Know your arteries means from the angiography we can know whether which is the artery involved. Coronary artery involved. LAD, circumflex, RCA. Occlusions each produce distinct MI patterns.